So second-line therapy in metastatic castrate-resistant prostate cancer, the guidelines, particularly the NCCN guidelines, have really expanded dramatically in the most recent update from the NCCN on prostate cancer. And again, they really give a lot more options than were available before. The key take-home message, though, when you talk about second-line therapy is looking at visceral versus non-visceral metastases. And going back and forth, you don't see a lot of difference in the second-line therapy guidelines, except when you get down to the visceral metastasis question. Why is that important? Because in the second-line therapies, visceral metastases knock out sipuleucel-T and they knock out radium-223. Aside from that, there's a very wide spectrum of drugs. If someone was on abiraterone now, you can go back to enzalutamide. If they're on enzalutamide, you can go back to abiraterone. Cabazitaxel, though, still is pretty much reserved for the second-line setting. While there's been investigator-initiated trials using it up front, when you look at the guidelines, cabazitaxel is still recommended as a second-line therapy in the NCCN guidelines. But taking patients back and forth is what the very interesting thing is with the NCCN guidelines. So using things such as ketoconazole, using things such as nonsteroidal anti-androgens, they were used up front, and they're also possibilities in the second line setting. So we have just so many more drugs available. 2 or 3 years ago, second line setting was pretty much mitoxantrone for palliation, and cabazitaxel's been around for 2 or 3 years now. But now the NCCN guidelines really give a lot of flexibility in going back to agents. Maybe agents that you tried before that are not working, you can revisit them. And so that's been the whole new world now in second-line therapy with metastatic castrate-resistant prostate cancer. So for second-line therapy, enzalutamide versus docetaxel or abiraterone versus docetaxel, really today we're going with the oral hormonally active agents in many cases before docetaxel. Let's be fair, many patients don't want cytotoxic chemotherapy. Docetaxel is cytotoxic chemotherapy. We know it's safe when given properly, particularly with support of the bone marrow and giving agents to support the marrow suppression. But enzalutamide and abiraterone has such good safety profiles in general that very often today they are used before docetaxel. Again, that's not wrong to say that docetaxel should not be used initially, but again, it's up to the medical oncologist to evaluate each individual patient and decide what is the best for them. Some medical oncologists would say if you have very bad disease, very painful disease, maybe you should go right to chemotherapy, as it might provide more immediate relief if there's a lot of morbidity and mortality with the prostate cancer. But again, it's an open question. The good news is where we are right now, we have guidelines which are actually broadening rather than becoming more limited. However, at that same time, they're actually becoming more focused to indicate which might be the best choices, for example, as we keep talking about visceral versus non-visceral metastatic disease.